Okay, so welcome to the Davies, good afternoon and welcome to the Davies Use Case webinar being presented by Duke Health on Care Redesign. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety here at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improve the patient and business outcomes resulting from health information technology-enabled care delivery. So it's my pleasure to welcome our speakers from Duke Health today.
Arnold, thank you. It's really a pleasure to have the chance to represent Duke Health and many of the clinical teams that worked hard to make positive impacts on care for our patients and to realize reductions in waste and improvements in efficiency. So I'm glad to share some general thoughts and reflections about how we've approached care redesign as an organization, and then quickly to turn it over to the real shining stars, Dr. David Atarian, Jenny Wall, and Dr. Heather McLean, who have really done the hard work to bring together their respective teams to develop and implement changes and improvements for care for their patients. And a little bit about my background. I'm a hospitalist and a general internist by training. I work at Duke University Hospital clinically, and I've held the role of medical director for Care Redesign for Duke University Health System for the last 5 years, and really have had the pleasure and privilege of working across Duke Health, our 3 hospitals, including impacts in the outpatient setting as well, working to really empower our clinical leadership teams and our administrative leadership teams to make positive impacts for our patients. I suppose it will come as no surprise that for us, like many, the passage of the Affordable Care Act really accelerated the pace of a lot of the work we had started as an organization to focus on improving outcomes for our patients and reducing the total cost of care. Where that piece of legislation gained most attention, expanding access to health insurance coverage, we really also viewed a lot of positive steps towards recognizing the concept of value and beginning to really expedite the conversations about value both locally and nationally, specifically through programs like value-based purchasing, the hospital readmissions reduction program, and then probably most critically, the creation of the Center for Medicare and Medicaid Innovation, which subsequently resulted in voluntary bundled payments, multiple tracks in the Medicare Shared Savings Program, mandatory bundled payments, and most recently the next wave of voluntary bundled payments, I think really igniting conversations at Duke and among other peer academics and community delivery systems around the country about how we can more concertedly focus on opportunities to improve outcomes for our patients and reduce the cost of care. Our executive leadership team saw this legislation, along with pressures from payers locally looking for reductions in reimbursement by as much as 20%, as a clear sign that we as an organization really needed to empower our clinical experts at the bedside with a charge, with the right governance structure, and with the right team to help them navigate change in a complex organization. And so our executive vice president and our chief medical officer chartered a committee which they currently still co-chair called the Care Redesign Oversight Committee, whose goal at a very high level was to improve patients' experience of care, improve the health of populations that Duke serves, and to be more judicious in how we use our resources, really focused on the cost of care associated with achieving those improved outcomes. And so using the principles of change management focused on creating a guiding team, the Oversight Committee charged myself and a small team to come up with an approach continuing to focus on how we can get the care right first for patients. And so we really have maintained our efforts centered around this concept of value, or how we can deliver the best clinical outcomes with the most efficient use of resources. And we focus specifically on variations in clinical decisions and how we can use evidence and how we can use internal data to inform what our best practice standards should be. And we've really looked to information technology tools to enable change, to allow our provider teams to make it easier to do the right thing for patients, so that when we know we should be making decision X, we can make it easy to make decision X, so that those even tougher decisions Y and Z can attract and warrant more attention from our providers. And we really look to the Oversight Committee with a series of responsibilities, and that group consists of, as I mentioned, our Executive Vice President and the Chief Medical Officer for our health system, but also, quite importantly, our Chief Nursing Officer for the system, our hospital presidents, the Vice President over our Performance Improvement Department, our Chief Information Officer, leaders from finance, our clinical department chairs on an ad hoc basis, and several other executive level leaders across the organization who really came together to figure out how best to enable change, how to break down barriers, how to equip our teams with the information they needed to design care processes to make it easy to deliver the right care at the right time for the right patient. And so we have historically used a Six Sigma framework for our approach to improvement, and we've really adapted that framework for the way we've approached our clinical teams. We start by clearly defining a problem, identifying clinical, typically nurse and physician leads along with an administrative lead, to populate a group of stakeholders with the right people to bring to the table to investigate opportunities to really improve care for patients, improve outcomes, and to understand how we can deliver those outcomes most efficiently and most effectively. We've also relied heavily on our IT tools to support those work processes, and also to begin to help our teams have insight into some of those key performance measures so that they can monitor sustainment of changes over time. And we have left it to clinical teams to provide the types of insight into where opportunities exist to achieve those goals. And we've been really excited to help empower leaders across a variety of clinical areas to focus on opportunities that are very patient-centered at their heart and range from minimizing opiate use to improve pain control, from improving access to therapies in locations that are a little easier to get to than coming into the hospital, improving the timeliness of therapies, avoiding complications. And really at their heart, we are looking to our clinical experts to really provide guidance about where opportunities are greatest to improve outcomes and to improve efficiency of care. We started out, as I mentioned, thinking about some of the changes that we needed to get a jump start on preparing for should they wash over our marketplace. And bundled payments were certainly one of those that helped us to develop an approach to interact with multidisciplinary teams focused on a 90-day episode of care. And so our first forays really involved empowering experts in cardiac and orthopedic and neurology to design care pathways for some of the common procedures and conditions they managed, really reviewing evidence and developing order sets, developing transitional care tools to help patients experience efficient care and to focus on opportunities to improve patients' experience of care. I think we realized pretty quickly that bringing together a group of multidisciplinary experts, equipping them with data, equipping them with project management resources to really focus on improving outcomes and being judicious with the resources at their disposal, it didn't matter how you got paid. That was just the right work to do for us as an organization and for our patients. And so we really subsequently focused on efforts to spread that mentality further across CT surgery, across other areas of general surgery, pediatrics, general medicine, OBGYN. And I'm proud that you will hear today from two of our experts who've been longtime champions of this work, Dr. David Atirian and Dr. Heather McLean, about the thoughtfulness they put into their approach for hip and knee replacement and pediatric asthma, and also, much more importantly, the positive impacts they've been able to have for patients. And so after those initial forays, we really received a charge from the Oversight Committee to focus on expanding efforts and to develop a process to more systematically identify areas with variation in practice. And so we grouped DRGs according to rough clinical populations, and we used variation in direct cost as a method to approximate variation in clinical practice. And so a lot of our subsequent work from fiscal years 14 through 17 have focused on some of those areas where we felt we had continued opportunities to reduce clinical variation in practice, improve outcomes for our patients, and be more judicious stewards of the resources we were bringing to bear. And I mentioned early on that IT has been a critical enabler, and I just wanted to share a few examples of how that's really played out within our team. So our spine surgery team found that in more cases than we cared to realize, surgeons and patients at the last minute were receiving notifications from payers that their case had suddenly been denied. And so cases were being canceled sometimes up to the day before or the day of surgery, because we really had an opportunity to make it easier to document the clinical details payers were looking for so that our revenue management office could more efficiently receive authorization for those procedures. And so even today, I chat with colleagues in our patient revenue management office, and they point to this interaction using a documentation template as one of the shining successes of how care redesign and surgical colleagues and revenue management have come together to really operationalize and make much more seamless a process to accommodate what payers are looking for. I also have heard even from primary care physicians who don't always view some of the electronic interventions we've tried to deploy as helpful, that the tactics we've used to communicate about complexities and unique clinical circumstances that an individual provider sees less often have been a really effective communication tool. And so we've used a best practice advisory for some of our most complex patients who have ventricular assist devices and need very specific considerations, whether they're in clinic or they're in the hospital, to make it easy for any member on the care team to understand some of those nuances. We have also focused on tactics to use our IT tools to promote standards in clinical care delivery where sometimes practice may have varied widely. You may have seen the pediatric ICU as one of those locations on our prior list, and we found working with leaders in the PICU that there were opportunities to improve the degree of standardization and the degree of adherence to what evidence would suggest was best practice for how we manage patients who are ventilated and patients who have pain in the PEDS ICU. And through the deployment of a more consistent protocol that's shared between nursing colleagues and physician colleagues, we've been able to see reductions in time spent on the ventilator, and in fact, reductions on the number of patients who are requiring hospitalization to be weaned off opiate therapy as a result of some of the changes in our sedation practices. And then finally, with the deployment of EPIC at our institution came access to a huge amount of clinical data, and some of our teams found that orienting that data in a way that made it easy for them to make the clinical decisions they needed to make was extremely valuable for some of our sickest patients. And so some of our transplant teams have really looked to reorganize some of the summary views they have of their clinical data, which has allowed them to make more efficient and timely decisions for their patients and improved some of the tactics they've been able to use to transition care earlier from the inpatient setting so that those patients can get back home and recover with their families. Then I mentioned a few minutes ago about reporting capabilities and wanted to also emphasize that some of the new data available through our electronic health record has really helped us keep eyes on some of those process measures of most importance. And so we've worked with our infusion therapy clinic to implement a treatment plan process so that, again, our patient revenue management office has time to obtain the approvals necessary once a treatment plan is entered for patients. And also, so probably even more importantly, pharmacy colleagues and nursing colleagues have time to prepare for those treatments when patients are going to be coming into clinic. And I'm showing a screenshot here of some of the variety of different examples of how we've been able to use the data that's become much more available through our electronic health record to really support sustainment of the changes that many of our teams have put into place. And those changes have resulted in some meaningful impacts for our organization. So we've been able to help some of our sickest patients leave the hospital sooner without seeing marked impacts on readmissions or some of the other balancing measures that we look at when we look at length of stay as a measure of performance. And then I mentioned the pressures from payers at the outset. We've also seen a lot of positive benefits by focusing on improving quality and improving outcomes for patients in terms of realizing meaningful cost savings. And so we've been able to see an improvement in our margin as a result of being more efficient during the inpatient stay across our teams. And so we have used some mechanisms to track benefit through the first 4 waves, and then we changed our approach to tracking benefits a little bit so that it's not quite so retrospective looking at our baseline performance. We've actually worked closely with colleagues in finance to develop a mechanism using a case mix index adjusted cost per case to set targets and measure performance looking ahead so that we can continue to monitor the benefits of this type of work as our pressures from payers continue to mount in our area. It's really important for us to be able to continue to focus on some of those areas most within our control in terms of being able to manage the cost of care. And so I hope that I've done a reasonable job of painting a picture of our work over time, working with teams to focus on improvements in patient satisfaction, improvements in our level of engagement with patients and with some of our sickest populations in the organization, and how we've been able to use data from our electronic health record to really inform how we can improve care for patients and then can realize financial savings as a result of that. And so now I'm really glad to be able to turn it over to my colleagues on the total joint team to describe in detail and to paint a much clearer picture for you of how this work impacts patients who are benefiting from the improvements in care, and also the clinical teams that feel even more empowered to be able to drive positive changes in their work day in and day out.
George, it's a pleasure to be able to present our experience with the total joint hip and knee care redesign. Jenny Wall and I have been working together for over a decade, and We've had quite a few different projects in this regard. I currently serve as the Chief Medical Officer for the Private Diagnostic Clinic and also the Vice Chair for the Department of Orthopedic Surgery. And Jenny has been our lead administrator for the musculoskeletal and spine clinical service units at Duke University Hospital for, again, over a decade. And so she's really the heart and soul of many of these projects for the physicians. So I'm going to share what we were able to accomplish with joint replacement surgery. We had done quite a bit of care redesign leading up to this in 2013, 2014, but then CMS, of course, intervened and mandated that we participate in the CJR, Comprehensive Care of Joint Replacement program. So we already had quite a few IT resources. The data was pulled. So this first slide that I'm showing really is the CJR cost attribution. This was sort of one of the key items that we addressed during care redesign. And as you can see from the first slide, we were able to really divide up the cost of any given episode for an inpatient total joint at Duke Hospital. So no surprise, 50% of the costs were really embedded in supplies and devices. And then we had room and board, perioperative services, pharmacy, and so on. So this gave us a handle in terms of where we were with our current state. Then we had to look at, of course, at what CMS was actually asking us to do. And basically, they were looking at DRG 469 and 470 with and without hip fractures. So we pulled our historical data. The bottom 469 and 470 were of main interest, and we could see that the bulk of our business was DRG 470 without hip fractures, which essentially is the elective total hip, elective total knee, and in our case at Duke University Hospital, also elective total ankle replacements. And so, given our experience with care redesign and the data that was provided to us, we looked at first utilization of the premium implant usage standards. We used our supply chain people to look towards opportunities in vendor consolidation, or at least in terms of more attractive contracts. We also looked at our use of medications and worked with our pharmacy on reducing costs there. We worked aggressively with our anesthesia team to improve our pain management. And then we also used navigators to improve how we could discharge people home rather than other post-discharge dispositions so that we could provide better value there as well. And so our design focus, at least initially for the CJR, is that we took our data sets, we set our priorities and our direction, and again, Jenny really deserves credit for that. On the physician side, we worked really hard on risk stratification. For many years, I don't think we really paid attention to that too much, but we started really understanding our patients' comorbidities and how that contributed to complications, longer length of stay, readmissions, and so on. And then we really measured performance and the impact of each of the initiatives as we went forward. And then our IT team built dashboards for us so that we could really keep track of everything on a regular basis and in real time. So the dashboards were inclusive and functional and really, again, provided continuous feedback and, in our case, also complete transparency for all the providers so that we could see who was performing well and who was not performing so well, and then share best practices. And then this next slide, this really provides the detail of our risk stratification work, and this was achieved by a group of orthopedic surgeons and anesthesiologists so that we could come to some consensus about what was really important. So how do we develop a risk stratification tool? And then also potentially with changes that are coming from CMS, how can we differentiate those patients who could do well in an outpatient scenario? So we needed to understand what factors were important, which factors really didn't matter. We looked again at comorbidities and demographic factors. And then all of this hopefully was going to improve the care delivery overall. And so in this box you can see that what really was important, this was done by one of our statisticians. So at least overall we felt that the ASA or anesthesia categorization was important. BMI seemed to contribute. Older patients, hypertension, electrolyte disorders, which is really abnormal kidney function, depression, and then, of course, home status seemed to make a big difference in terms of how people did. And then in the blue box, demonstrating that, which patients could we realistically transition to the outpatient pathway. And so in general, probably BMIs less than 35, age less than 70, people who really did not have depression or other psychiatric diagnoses. People generally had to have good support at home, and then they usually were going to be ASA 1s or 2s. The other items that we had to work on, so the CGR by CMS mandated that we also had to learn how to collect PROs, so patient-reported outcomes. We had to do this before surgery. We had to do this within a certain period after surgery during the episode. And so our IT team was able to take sort of our standard PROs that we frequently used. And so these were built into our Maestro Care platform, and so they're outlined in red. So we had a RAP score for the total ankle group, which they had been using prior to the CJR. Along with the CGR, we had to build in the PROMIS global health and pain measures, and then traditionally, at least in hip and knee, we had been using the HOOS and COOS Junior, so the knee and hip osteoarthritis PROs. And those were built electronically, which obviously was a huge benefit for us to document that this bit of data was being collected, and then we could report it accordingly when CMS wanted the follow-up. And then these were gradually rolled out also to tablets. Our navigators were able to push these out on MyChart, which was really helpful, and so our performance on PROs gradually improved. This slide just demonstrates how some of the PROs that were collected could then be used through the Maestro Care system to populate flow sheets. This was an easier way for us to, again, see how the patients were before and then how they were after and whether our interventions were actually making an impact. This slide demonstrates a particularly helpful BPA that was created. One of the things that happened in many episodes is that once patients were discharged, we had a really hard time with continuity, and especially at Duke Hospital, where patients would potentially go out, maybe be an hour or two away from us, and then they would run into other problems, and we would never hear about what was going on. They might even stop into one of the Duke Health System urgent cares. They might stop into one of their primary physician's office. They might show up at a Duke Health ED, and people would not know that they were in a bundle. So this BPA in particular was extremely helpful. So when any patient was in their 90-day global period of a CGR bundle, the minute someone opened up their chart, this BPA would fire and alert them to know, first, this is a CGR patient, you need to know this, and then there would be some automatic recommendations about consultations, in particular to consult orthopedic surgery so that the responsible surgeon knew immediately what was going on with their patient, also to consult the case management group, who were the navigators for CGR. So literally once a patient came back into the system in an unanticipated way, the people managing the patient would know immediately. And this really improved continuity of care. It reduced our readmissions. It really allowed us to potentially intervene with complications much sooner than we had in the past. And this just lists some of the other opportunities that we took advantage of in the CGR program. So we really developed very robust pre- and post-operative order sets for total hip, total knee, and total ankle. These were all built so that everybody had these available. The nurses had standardized teaching plans and neuro assessments, which also helped us actually with our Joint Commission accreditation for hip and knee. We came to an agreement about the multimodal pain algorithm as being advised by the anesthesia service, and so these were built. Again, as we previously discussed, we had risk stratification and predictive modeling that was built into the electronic record. Another nice service that was developed as a result of this program was meds to bed. Specifically, what would happen is that when a patient was getting ready to be discharged, our APPs who cover the ward could actually send a message to the pharmacy, and the pharmacy would actually see exactly which medications the patient was going to be discharged with. And rather than the patient being given some sort of electronic or paper prescription, literally within a couple hours, the pharmacy would deliver the medications to the patient in their room before they left. And so that really helped patient satisfaction. Of course, we developed quite a few different smart phrases. In particular, we had standard smart phrases for wound management, activity precautions, just general after discharge instructions with contact numbers. All of that improved continuity of care after people were out of the hospital setting. Again, we already mentioned some of the alert banners. We had a separate alert banner, actually, that also would just label a CGR patient in general, but then, as I mentioned, the BPA that would alert somebody that this person was actually in the 90-day episode so that the people taking care of the patient would know right away. And then also the PROs were built into our system, all tremendously helpful. So this is some of the performance data, and again, in sort of pulling the discrete data out of the record, I think for the first time we were really able to understand what was happening to our patients after discharge. So we were able to track our primary knees and our primary hips, for instance. This is on a monthly basis beginning in February 2017 through January 2018. And we were able to assess which ones were actually being readmitted, and those are the ones in red. And we could actually click on those and really dig into why were patients coming back and were these readmissions preventable. And that's been tremendously helpful for us in terms of improving care overall. We also had this very transparent dashboard, which we shared on a regular basis. So this data that you see, on the left you see the names of the surgeons. So the specific surgeons by total hip arthroplasty, total knee arthroplasty. You can see the number of cases that each person happened to do at any given time. You could compare the average length of stay, the length of stay index. You could see the average ASA rating, and you could see the readmission rate. And for all of us to look at this on a regular basis, we made a point of reviewing this as a group every month. Again, we could really detect any surgeon who might be having difficulties, outliers. We could also share best practices. And overall, that really resulted, after we went through transparent case review, we really had significant process improvement. This is just another slide that actually Jenny put together for us so that we could clearly understand, what were our initiatives, what types of tactics were we taking, and then what were the impacts. And so she would lead these discussions with the surgeon group, and then necessarily we would end up actually improving what we did. So for instance, we wanted to improve our advanced planning. Specifically, we wanted all of our patients to know in advance of their elective admission where they were going to go when they were discharged. Many times in the past, none of this had really been clarified until the patient got in the hospital, and then there would be delays in discharge and so on. So our lever was to really improve the tactics to identify these patients. This was done by our navigators. And so every patient who's done elective hip, knee, or ankle at Duke Hospital, the navigators will contact prior to the admission and really discuss exactly what the patient's going to do at the time of discharge, and also discuss actually how long they'll be in the hospital. And that really helped us reduce our length of stay. Also, looking at what was the post-acute disposition. So at many hospitals with total hip and total knee, you'll see a significant number of patients going to skilled nursing facilities, many patients getting home health, some going to acute inpatient rehab. In fact, the greatest opportunities and cost savings for bundles is how you manage the patients after they leave the hospitals. So in our case, again, we really look carefully at partnering with some specific skilled nursing facilities who, for instance, would agree only to keep the patients for, let's say, 10 days instead of a full month. We also look very carefully at really sort of convincing and showing patients that they could safely go home, and maybe they would need home health care for a brief period of time instead of several weeks. Also, I think that we worked on enhancing the patient experience overall. So we really standardized our pre-op teaching classes across the board. We had scripting in terms of communications with the patients prior to admission. and this really helped improve, I think, our HCAP scores overall. And then we continue to work aggressively with our supply chain in terms of really standardizing contracts, working on using basic constructs for different types of patients, or matching premium devices only to high demand patients, and we ultimately realized significant reduction in implant costs overall, and without affecting the quality outcome. So here just happens to be some of the data in terms of what we were able to accomplish with lengths of stay. So you see data from 2015, 2016, 2017. The upper graph is hips, the lower graph is knees. And we really saw, at least for the first 3 years, significant reductions in length of stay. Now for knees, for 2018, the problem we're having is that a lot of our previously short stay knees have been converted over to outpatient, and so they're not included in the length of stay. So our length of stay for knees in the bottom graph appears to have gone up a little bit, but it's only because now 20% of our knees are considered outpatients, and they would have actually lowered our length of stay if they had stayed in the inpatient category. On the hip side, actually, we've had a bit of a blip in terms of our length of stay, and we've been able to look at that with our data analysis on a monthly basis. It turns out that at Duke University Hospital, we're getting some very complicated primary hips to do, and some of these were actually patients who had had previous hip surgery, and so they were converted to total hip, and so we think that the length of stay, even though longer, is appropriate given sort of the case mix that we're dealing with. On this slide, and I'll give kudos to our performance services team, Clara Howell, who leads that for us. On a monthly basis, we review all of our HCAP scores. And again, this is done in dashboard format. It's discussed at a monthly meeting. All of the surgeons are there to see everybody's sort of results. And then here, as you can see on this dashboard, we've looked at really all the Press-Ganey questions, such as communication with doctors, communications with nurses, overall hospital rating, pain management, and so on, and then divided by hip and knee. And we actually have this boiled down to specific surgeons. And then we talk about, problems when we have them. That's really allowed us to improve our patient experience overall. This, again, is something I mentioned, which is we've really gradually improved value in terms of discharge disposition for our total joint cases. So here you see the data for primary hips on the left, primary knees on the right, and it's by 2015, 2016, 2017, and then through a period of 2018. The blue is how many patients actually just went home. The red is how many went home with home health. And then the green are those cases that required a skilled nursing facility. And as you can see in the primary hip, we've sent more and more people home. We've gradually reduced the utilization of home health. And more specifically, we've reduced the utilization of skilled nursing facilities. And then on the right, again, total knees. We've been able to send more people home, which is good. We've been able to reduce the utilization of home health and also the use of skilled nursing facilities. And as we look at our outcomes have not changed in any way, and we've not had any more readmissions or complications overall. This is another interesting project that we've initiated this year. This is really what we call DHI, which is the Duke Institute of Health Innovation. And so what you're seeing in front of you is a graph comparing 4 of the surgeons, actually, excuse me, 5 of the surgeons at Duke Hospital. I'm not counting myself, but we were able to take the previous most recent quarter, and we were able to show everybody in terms of their actual cost per case on a monthly basis for hips and knees. This happens to be the graph for hips. And so you can see cost per case in the upper left-hand corner. You could see how long we did or took to do the surgery in the upper right-hand corner. We could see the length of stay in the lower left-hand corner. And then there were really another sort of graph which actually looks at the cost range for each particular surgeon. And what this does, so when a surgeon actually posts an elective hip or knee in their office, 24 hours later they get an in-basket message, and then when they open the message they get this report, and then they can see, okay, I posted a primary hip. They go into the in basket, they see the message, they open this up and they get this graph and they can see, okay, in the last quarter or more, I can see exactly how I performed with this type of data and then compared to my partners, and then I can see if I'm improving or if I'm an outlier or if I'm the best practice and so on. And this has been really a very useful conversation. Here we also just have another example of monitoring tools. This comes out in a dashboard that Clara Howell puts together for us so that we can see by particular cases. So in this case, it's Duke University Hospital. We can see how we as a group are performing in primary hip and primary knee. And putting the group data together, we can pretty much track trends and intervene in real time if we perceive we're having a problem. We also share our work. We're very proud to say that for our national meetings, so the American Association of Hip and Knee Surgeons and also the American Academy of Orthopedic Surgeons for the coming year, we turned in over 59 abstracts. And in fact, just recently we learned that 20 of the abstracts were accepted for either poster or podium presentation at our hip and knee meeting that's coming up in November. We hope to be equally successful in terms of what we've turned into our Academy meeting, which will be in March. And again, we're doing everything we can to keep improving, and we leverage IT every chance we have. So we are in the process of putting together some online videos for patient education for anyone who might be having a total hip, total knee, or total ankle in the Duke Health system. We've started to put together short vignettes for FAQs and also some patient testimonials, which has been really useful so we can direct our patients to those bits of information on our website. We're switching over to some live webcasts. So some of these are actually for the teaching class, and in some cases, some of my partners are also actually demonstrating new technologies in the OR, and these webcasts are done regionally and nationally. We're working really hard on increasing our post-op day zero discharges, which are effectively outpatient cases. We're working hard to prepare for the future because we believe that at least 10 to 15% or more of our primary hips and knees will be outpatients going forward. We're working with the Medicare ruling as really at least 10% of our total knees are converting to outpatient, and we have to understand how that impacts the hospital financially. We are continuing to work on our pre-surgical opportunities, which is really, again, risk stratification and predictive modeling. We keep using our HIT for really navigation and supporting clinical initiatives. We're developing more apps that are applicable to the patients to help them manage their recovery and maintain continuity. We're working, again, to assess 30-day readmissions. With our outpatients growing, we are also tracking data on return to the ED because if someone just comes into the ED and they were never admitted, we may not know about that. So we're pulling that data to really monitor our patients that are having problems. And again, the IT provides this data in real time. We're continuing to build different types of alerts, reports, dashboards, and we're working hard to optimize what's available to all of our patients in MyChart. And in fact, at Duke Health, we have one of the highest rates of MyChart usage anywhere in the country. And so with that, I appreciate being able to present this data on behalf of the Total Joint team. Again, Jenny Wall has been an absolute star in helping us. And then this will lead into Heather McLean giving her experience with pediatric care redesign.
Hi, my name is Heather McLean. I have the pleasure of presenting on behalf of my team the Pediatric Asthma Care Redesign as a case study. First, a little bit about myself. I am a pediatrician and I work as a pediatric hospitalist. I'm also Vice Chair for Quality in the Department of Pediatrics and a Director of Quality and Safety in the Children's Hospital. I'm going to talk to you today about this work we did a few years ago on pediatric asthma. Our goal was to improve the efficiency of care in the hospitalized setting, so both the emergency department as well as the inpatient and ICU setting. What we had found is that pediatric asthma length of stay and cost per case at our hospital was higher than seen at other academic medical centers. The goal was to standardize and improve the efficiency of care for inpatient asthma exacerbations from the initial presentation in the emergency department and throughout the hospital stay to home. We developed emergency department and inpatient guidelines that included an asthma symptom score flow sheet that we implemented and that was visible and used by an interdisciplinary team. We had inpatient emergency department PICU specific order sets that we created. As part of this guideline, we developed a respiratory therapy-driven albuterol treatment protocol that used the asthma score embedded into the order sets. And from this, the respiratory therapist was able to continue to wean albuterol according to the score. We developed an asthma action plan flow sheet that was created at the patient level, and this can be used across care settings. So not only within our project, which was emergency department and hospital-based, but also in ambulatory settings in primary care and in specialty care. We also developed patient education materials and added them to the library. This is an example of some of the things we designed within our guideline. We developed this asthma treatment protocol using an asthma score called the Modified Pulmonary Index. That was an important part of this respiratory therapy-driven protocol. We, as part of testing and implementing this particular change, we found that this was a real delay in of our care delivery and certainly was very variable across the hospital platform. And once we put this into place, we were able to speak a common language, we're able to provide standardized care, and do it in a much more efficient way. This tool became part of our standard language and handoff between different settings and different providers who were taking care of patients with asthma. Here are some examples of order sets that we created as part of this guideline. We developed actually 2 order sets within the pediatric emergency department. One was a triage protocol for when the patient arrived in triage and could get started on treatment quickly, and then a different order set for patients who were sicker and needed continuing care. All of these order sets had some common standard language, as well as all of them had the scoring system and this respiratory therapy-driven protocol. We developed a flow sheet where people could record the MPIS score, which is our asthma score, and this standard assessment tool of pulmonary symptoms and functional status across standardized assessments. And when we tested this both in the emergency department and in the inpatient setting, we tested it with various roles, including the respiratory therapists, physicians, attendings, including specialists, as well as residents, nurses, and other providers that were taking care of the patient. This really allowed us to be able to communicate where the patient was at any given moment and to be able to guide care. This was really a critically important part of standardizing practice. This is an example of the patient asthma action plan. We created it using a flow sheet. So when the patient was seen in the inpatient setting and getting ready to go home, or when they followed up later, whether it was in specialty clinic or in their primary care clinic, or if they happened to present again to the emergency department, you could see, because it was at the patient level, what instructions they were given and what teaching they had. We used this flow sheet to input the data and then incorporated it into a more patient-friendly document that could be printed out and sent home with them. Here's an example of some of the patient education materials that we created as part of this project. We created some different types of materials about how to use different devices, about asthma itself, that were much more patient-friendly and at the appropriate reading level. This is an example of how we monitored the use of the tools within our guideline to make sure that they were being used in driving care. So this is, to orient you to this slide, this is an example of a control chart. We monitored this process measure that reported order set usage that allowed for feedback to users, and we did monitor this throughout the project. So on the y-axis is the percent of asthma order set use. So within this included either a PICU order set or a hospital order set, and then you can see time. You can see in the solid red line is the mean line, and that increased as we continue to work on things to make this more readily available and visible to people who are providing care. We believe this was an important part of making sure that as we built the tools within the electronic health record, people were using this, and this was going to drive the outcome that we wanted. This is an example of our project control chart, and this shows the average length of stay. We were able to decrease it from a baseline of 3 days to just under 2 days at the end of the project, and this has continued over time. Again, this is showing months on the x-axis and length of stay on the y-axis. The desired direction of change is down. The mean line is in solid red, and you can see the upper and lower control limits in the dotted line. We had a variety of interventions, some of which I've already included earlier, such as targeted education, MPIS testing, use of measurement performance. We gave people information that showed how they were performing. We did some small tweaks to make sure that it was available and visible to everybody, and we found this to be very effective over time and have been able to sustain our results. Another way of seeing some of our outcome data. This table shows the average length of stay, our readmission rates, and some indices for length of stay and variable direct costs for our pediatric asthma patients in the baseline and in the intervention groups. You can see that there's been a significant change both in hospital days and length of stay, which really drove some improvements in costs. We were able to realize a savings of about $1,500 per case without changing readmission rates. So overall, we were able to realize an improved direct cost with a 24% reduction in direct cost per discharge from the beginning in fiscal year 15 through fiscal year 18. We've resulted in annualized cost savings of just over $100,000. We've been able to sustain our results in average length of stay and readmissions through this period. You can see in this table our total discharges per fiscal year, average length of stay, our length of stay index, our case mix index, and readmission rates, as well as mortality. So in summary, this asthma work has led to some other structural improvements within pediatrics. This asthma pathway revision began just this past fall in 2017, and we use this as a case example to build upon other pediatric clinical pathways that don't fall within the care redesign plan. Our overall goal is to improve the effectiveness and quality of pediatric care by implementing these clinical pathways with measures of effectiveness and using the electronic health record tools, which was certainly critical to the asthma work. The current 3 pathways that are in production right now, actually we just finished our asthma revision. We're working on a headache referral pathway that involves primary care, neurology, and the emergency department to standardize care and hopefully improve the efficiency of referrals. And then hyperbilirubinemia, we are working to standardize care across primary care settings, all of the nurseries, emergency department, and inpatient setting. This is an example of our timeline for our pediatric clinical pathways. You can see the asthma pathway, headache referral pathway, hyperbilirubinemia pathway, and all of the parts, all of the stages in between. I hope you can see in this slide how important embedding the tools within the electronic health record really is to the success of being able to track process that can lead to outcome. Without hardwiring these changes into the electronic health record, I don't think we would have been able to see the results we did in our asthma project. Thank you.
Thank you for the great presentation and for joining our Davies webinar today. I just want to remind folks where to go find this webinar, this recording of Davies use case and other Davies use cases, and information on how to apply for Davies Award. And that information can be found at HIMSS.org/Davies, and there you will find other very interesting and great recordings on Davies outcomes. So thanks once again to Duke Health, and this concludes our recording.